Every time I see your name, I just say, thank you, Lord. Lori Engel, my heart just melts because she was actually told by the doctors that when we first met, she had like, I think 6 months to live. She
No.
had until Christmas of last year to live, and she's
Wow.
still alive. She's with us today. Lori is in the group with us right
Yay.
now.
Yay.
Yay.
Yeah,
Thank God.
so she's a miracle.
A
Thanks.
miracle.
Yeah, she is.
Oh, mm,
Yeah, she is.
Beautiful.
And every one of you are too. It's just amazing when a person lives past that prognosis
Yeah.
time. Carson Patterson, he when I first met him, he had 10 months to live, and we have the same birthday. I think that was 2 years ago, I want to say
Wow.
October.
At least, at least.
At least there you are, Carson. All right.
I'm here.
thanks,
Good.
Lawhern.
Yes. Good evening, everyone, and thanks for joining us for Doc Talks Season 4, Episode 17. We're so happy everybody could join us tonight. Dr. Tennant has a great message again, and we've got Dr. Ibsen with us too, and our Doc Talks family. We're looking forward to what you have to share with us, Dr. Tennant. It's all yours. Take it away. Thanks so much.
Well, thank you, Jimmy. But I think the first thing that we got to do is send some criticism your way. You said that Lori was a miracle and that she was unusual. That's not true. This program creates a lot of miracles. I mean, our goal is to keep you living past everybody's expectations and living better. So you're just going to have to shape up and realize this is the miracle program. So anyway, now that you've been admonished, we can move on. All right, I'm going to start the program today by a letter that was actually received by our good friend Red Lawhern. And as a lot of you know, he's been a real advocate and champion, and he's a man who is probably, I single-handedly believe he kept treatment alive after the real CDC guidelines, and his advocacy is spread. But anyway, he gets a lot of letters, and frankly, he'll ask me to respond to some of the ones that are medically oriented. And he received a letter today, or a couple of days ago anyway, that is one that is just like a lot of them I've been getting here in the recent days, and it's a main issue. Let me read you the letter, and then I'll talk about what the issue is, because it affects pain patients in every state. There's something new going on that everybody really needs to know about. Here's the letter. It says, "Dear Red, I am curious as to whether or not it is currently widely practiced to prescribe medication such as misoprostol and Topamax in conjunction with buprenorphine for chronic pain, or if it will be." And Red writes her back and says he's going to refer this to me to answer. And I'm glad he did, because the issue that we're going to talk about for a while is the new drug buprenorphine. Now, due to the absence of media or any communication in the country regarding pain issues, there's something that's gone on that I'm afraid that isn't known. And keep in mind, I want to say one thing right out front. We have 50 states, and the Constitution of America does not specify federal treatment. So treatment is delegated to the states. And this is why anything we say on this program, it may be correct in one part of the country, but not in another. And so I want to make it clear that whatever I may say in the next few minutes is variable throughout the country. And so all we can do is kind of talk and make it clear that that's what we're talking about here. There is no federal law about pain treatment. There is no federal law about any medical treatment. FDA approves drugs for doctors to prescribe as they wish once they're there. The whole problem with DEA is that DEA has stepped in and say they are the arbitrator of medical practice in the country. And you can argue whether that's legal for them to do this or not, but they certainly have done so. But at any rate, in general, something has happened that is not well appreciated. Everybody probably listening to this has heard of the CDC guidelines. Well, there's something about pain treatment in America that exceeds that from the federal level. What the federal government has done, not by law, not by regulation, but by guidelines, not even written, but they've set standards. And what the federal government has done is, in their way, has sanctioned certain pain treatments, 4 of them. Okay? Now these are sanctions that they've given out, and they've done that by communicating primarily not with patients, not with the media, but through the medical establishment. In other words, I know all about them, but you don't, because they're not communicating with you. Now they've got 4 standards, and what the federal government and in their wisdom has fundamentally said is, if you want pain treatment, here is our sanctions. Number 1, your local methadone clinic. Okay. Number 2, an implanted intrathecal pump, or you can have opioids or fentanyl by pump. The third one is now the new one, buprenorphine, that is now sanctioned by the federal government. At number 4, they have what's known as the CDC guidelines, in which you can prescribe up to about 90 milligrams of morphine equivalents a day. Now, those are the 4, but the new kid on the block is buprenorphine. Now, you don't know about it probably, but every physician in the country does. And what they know is that if you prescribe buprenorphine, you're okay. It's the sanctioned opioid now for medical practice, in private practice and in clinics, and this applies to every nurse practitioner and every physician out there. Buprenorphine is the accepted opioid treatment. Now, when I say it's been federally sanctioned, what do I mean by that really? It means that the federal government has fundamentally blessed these 4 treatments. And they think they're doing their job. And so all this information has been passed down through the university medical centers, through the medical schools, through the insurance companies, through the medical boards, through the professional societies, and through places, sanctioned meetings such as Pain Week. Okay, most of Pain Week was dedicated to buprenorphine. Why? It's the sanctioned treatment now. And doctors are starting to prescribe buprenorphine throughout most of the 50 states. Not all of them, but most of them. And they know that if they prescribe you buprenorphine for your pain treatment, they're not going to be criticized by their medical board or DEA or their insurance company, their employer, who's 75% of doctors now work for a health plan, or their peers. Okay? So let me repeat these. Now, I know this sounds offensive to a lot of people, and probably is, but this is the new lay of the land, and why people that want to advocate and go to Congress and ask for bills and want to do this and that don't realize, from the government, federal government's point of view, they've got 4 treatments, and so the argument that they're not taking care of pain patients, they say it's not true. You got 4 options, and those options, let me repeat them. Your local methadone clinic, if it's a registered clinic. Secondly, an implanted intrathecal opioid pump. Okay. And thirdly, you now have buprenorphine. And then fourthly, you do have certain limits, and I'm going to read those to you in a minute, that go up to the CDC guidelines. Now, you sort of have in some locales a 5th option, and that's called palliative care. Now, a lot of the states have no longer recognized palliative care. So some states do recognize palliative care, and I want to say a few words more about that, because I do know people watching this, or some of you are getting palliative care, but the states got a sanction that the federal government doesn't really have much to say about that anymore. They want palliative care to go away. They really don't want to do it, but some of the states are still advocating it and recommending it. Okay, just for the sake, you may not have ever seen it, and if somebody wants to get a copy of this, I'd be more than glad to give them to you. Everybody hears about the CDC guidelines and the 90 milligrams of morphine a day. But what does that really mean? Well, there's a table. Okay. You've probably never seen it. Now, this table tells the doctors exactly what they can prescribe. Now, as long as the doctor doesn't go above this, he or she is fine. And so here, I'm going to just give you some of the common ones to give you some idea what this is sanctioned and what's okay. You can have 3 to 4 methadone a day of 10 milligrams. You can have 8 or 9 morphine tablets of 10 milligrams. You can have Percocet 10s, about 6 a day. You can have Vicodin, Norco, right at 8 to 9 a day. You can have oxycodone, 30 oxycodones. You can only have 2 a day. And so tramadol, you can have tramadol 100s, 8 or 9 a day. And so a fentanyl patch, you can have either a 25 or a 50. And so these are the guidelines. And then somebody that wants those, I'd be more than happy to send these to you. These are from the Medicare Centers for Medicare and Medicaid. And I think that people may want some of those. It's just a table. And frankly, I think that everybody have one of these. So when you criticize the CDC guidelines or want to go above this, you really ought to have the table in front of you so you know exactly what the doctor can probably do without anything bad coming to him. Now, let me throw out something else to you that is not going to go down well. If the doctor goes above these 4 things, buprenorphine, the intrathecal pump, the registered methadone clinic, or tries to go above those guidelines, the doctors now feel that they will not only be criticized, they will not only be sanctioned by their medical board, they'll be charged with a crime. So what they have done in this country, whether you want to hear it or not, and Dr. Ibsen, I want him to weigh in on this in a little bit. If you don't stay within those 4, the doctors are afraid they will be charged with a crime and go to jail or go to prison. So when you think you want to go outside that or it's wrong, well, you may be right, but nevertheless, the federal government quietly behind the scenes and in all these political years and all the controversies that the voters voted on yesterday, nobody realized that these things were being set in, not just set in, but in stone. I don't see personally any changes outside of what I've just talked about. Okay. Now I want to go on and talk about, get back to a couple of things. Let me say one thing about palliative care, and then I want to get down to what the question was about, and that has to do with the concept of opioid boosters. Okay. Let me say a couple of things about palliative care. Now, I know some of you watching this are able to get palliative care in your state. And from what I can see, based on our foundation's input, more and more people are getting palliative care. But again, it's spotty in the country. I mean, there are some states that if you try to go outside these 4 sanctions, you're not going to have much luck. But at any rate, palliative care, the ones that are getting it, and I think we had somebody on the show here, Allison Geisen here a couple of weeks ago who articulated it very well. She has her own personal medical record. And if you want to get opioids, particularly something in palliative care, something outside of the 4 sanctions, then you're going to need a good 3-ring binder with your MRIs in it, your laboratory tests in a day. You better have those Epstein-Barr tests in there. You better have some autoimmune tests in there. You better have some records showing what treatments have failed in the past, and they ought to be hand carry. Because of the buprenorphine issue and the belief, now, before everybody says, oh, that's not right, buprenorphine only has the power of about 4 codeines a day. It's not a potent opioid, but the government feels that's adequate at this point. And if you And at any rate, if you want to, get around that, you're going to need a good, solid medical record. Now, our foundation has for some time, in fact, we still encourage it, particularly with adhesive arachnoiditis or one of the spinal conditions. Our foundation gratis will review your MRIs and give you some suggestions, give you some ideas. But we're no longer going to let anybody send us a disk or a portal or a link. It's got to be an email images. Why? You need those MRIs to hand carry to your doctors. And if you say you've got a spinal condition, whether it's cervical, lumbar, sciatica, pudendal neuropathy, you've got one of these terrible spinal conditions, you are going to need your own MRI to hand carry. So I don't want anybody to kid themselves anymore. This idea, well, look on my portal or here's my link, that's not going to work. You've got to, in this day and age where everybody thinks you can digitize the world, digitizing your medical record or having an electronic medical record down at Kaiser or Mayo Clinic isn't going to cut it. You've got to have your own binder, your own records, and carry them around. And incidentally, there was a big article on the front page of the Wall Street Journal this week about how young doctors don't believe in the workaholic behavior of old guys like me. They only want to work 8 to 5 and take a regular salaried jobs. And the Wall Street Journal pointed out this is going to make medical care harder and harder to get. So you've got to not only carry your own records, but start learning how to better treat yourself, in my opinion. And I'd like to have Dr. Ibsen also weigh in on this in a few minutes. Now, what I want to get to is some news. It's not new, it's really old. But there is a concept called opioid boosting. Now, some of you are familiar with that, or some of you who have a medical background or a pharmaceutical background will recognize the term potentiation, meaning that you can take something with an opioid to make them more potent. In simple terms, they're opioid boosters. Now, in my day and age of being trained as a medical student many years ago, we were taught that you never gave an opioid to somebody unless you gave it with a booster. Now, the early boosters were, first and foremost, acetaminophen. And we still have that, like Percocet or the set, all that means acetaminophen. So you've got oxycodone plus acetaminophen. The acetaminophen boosts the opioid's power and also its extension. In other words, it's stronger and longer if you take the acetaminophen with the opioid. And that's what Percocet is. One of the reasons why Vicodin and Norco are so popular is that they also have acetaminophen attached to the opioid. Put in simple terms, if you know what boosters to take, 2 and 2 isn't 4, 2 and 2 equals 5 or 6. Now, the letter that Dr. Lawhern got this week asked about misoprostol and Topamax. Now, what's happening is because all over the country, doctors who are prescribing buprenorphine are realizing that the buprenorphine is only worth about 2 codeines. And so it's a weak opioid. Now, you're not going to be on 500 milligrams of morphine equivalents or on a fentanyl patch or OxyContin and transfer to buprenorphine. It's not potent enough. Now, you may be able to make some transfers if you take the buprenorphine plus the boosters. So right now, the doctors throughout the country are starting to pull out of the hat a lot of old boosters, plus a few are trying new ones. Now, in answer to this person's letter, Topamax is a favorite of mine. I think Topamax is one of the very best boosters. It's an anti-seizure agent. Anti-seizure agents such as gabapentin are great boosters. Now, Topamax is not very well known as a booster because it's so darn expensive, nobody can afford it. And the people I've known that have taken it as a booster, it's been worked great. but most people can't get it, and unless you have it, your insurance company probably won't pay for it because it's a seizure drug. If you can, it's a great booster, and Topamax along with buprenorphine works very well. Now, misoprostol is how it's pronounced, I think, is really an anti-ulcer drug taken a lot of times to keep from the NSAIDs from bothering your stomach, but it does have opioid boosting capability. And so doctors are starting to pull out some of these drugs and use it for that purpose. And so that's what this particular doctor is doing. He's trying Topamax and misoprostol to boost the effects of the opioid. Now, I'm going to give you a list of some of the opioid boosters. And in my opinion, anybody who feels right now today they're not getting enough pain relief, you need to try opioid boosters. Now, most people who try both, I get letters all the time that say, "Oh yeah, I take gabapentin and I take it in the morning, and then I take my opioids in the afternoon." That's not boosting. If you're going to boost the effects of an opioid drug, you must take the booster within 10 minutes before or after you take the opioid. In fact, it's usually a little better to take it right before. Bottom line, you have to take it right with the opioid, otherwise you don't get any boosting effect. But if you do take some of these boosters right with your opioid, you can get that opioid to give you more pain relief, and pain relief that'll probably last a lot longer. I'm going to give you a list of just some of the common boosters, and it's not a complete list. And I think with the buprenorphine now being almost the sanctioned in-office drug nationwide, you're going to see doctors trying a lot of different boosters. And guys, I hope they come up with some good ones. Let's hope anyway, because the buprenorphine is really here to stay. For example, let me tell you my favorite boosters. My favorite booster might surprise you. It's plain old Benadryl. You can go down there to Walmart and buy a whole bottle of 25 milligram Benadryls, and Benadryl taken with your Norco or your Tramadol makes it really work well. So plain old Benadryl. My other favorite booster is one of them is taurine. Taurine, you can get out a whole bottle down at the health food store for $10 or whatever it is, and you get maybe even 500 capsules of 1,000 milligrams each. Take 1,000 or 2,000 milligrams of taurine right with a Percocet, and you're going to get a lot of extra pain relief. Okay, so taurine is, now those are some of my favorites. I'll tell you one of my other favorites, which is a new one. You've heard me talk a lot about it on this program, and that's what's usually referred to as PEA, palmitoyl ethanolamine, and it's combined usually with luteolin. So I really like the idea. In fact, the favorite trade name is Marika. There's some other trade names that are fine. But the combination of your PEA and your luteolin, I find that's a great potentiator. I like to see that taken right with your morphine or your Dilaudid or your fentanyl, whatever. Again, I'm giving you my favorite boosters now. Not that they're the best, just the ones I happen to like the best. Another one I like is clonidine. Clonidine's been an old favorite around for a long time, a 0.1 or 0.2 milligram clonidine. I did a study back in the 1990s where I'd give a 0.1 milligram clonidine along with a 37.5 phentermine, and plus the normal opioid, and opioid doses were cut in half. So these things worked extremely well. Another one I like is kava, another natural one. The kava plant, it's the best natural substitute for Valium and for Lyrica and for alprazolam and Soma. The best natural substitute for that class of drugs is kava, in my opinion. And valerian root's another good one. And these are all good boosters. If you've got intractable pain, taking your Valium or your alprazolam right with the opioid can give you great pain relief. Now, they all try to say that everybody's going to overdose and die if you do that. And so you want to start at a nice low dose of Valium, maybe 2 milligrams or something, before you do that. Other boosters that have come along these days, just to give you some of them, your CBD products, your medical marijuana, kratom, amitriptyline, those are all good boosters. So let me wrap this up and then move on to our person to interview today. There's an informal network or an informal program of federal sanctions, and those sanctions have been adopted through the medical establishment, and they're kind of accepted by the insurance companies, the medical boards, the professional associations. But there's these four things: your intrathecal pumps, your local methadone clinic, staying within the CDC guidelines, or fourth, the new kid on the block, buprenorphine. These four are sanctioned. And now that's not in law, it's not a regulation. It's probably even more devastating for patients in a way, and that it's been put in place informally, and it had to be done this way because the federal government can't pass a law about this or a regulation. All they can do is saying, this is our suggestions. And they have done so, and that's because we've got 50 different states with 50 different medical systems. And so depending on what states you live in, these things will be implemented to a various degree. Bottom line, though, I do want everybody to know, nationwide, any physician, nurse practitioner, or PA, or naturopath in some states can prescribe buprenorphine as an opioid, and the doctors are not afraid of being arrested for criminal behavior or sanctioned, because that drug is now acceptable, the acceptable opioid to prescribe in the United States. Okay. Incidentally, in Europe and Africa, the compound paracetamol is what's the sanctioned one there, and that's used widely. It's actually quite a good drug. Again, weak, about the same power as buprenorphine. So again, you've got a nice weak opioid that's sanctioned nationwide, and boosting is here to stay. And let's hope the doctors come up with some new natural products or something that'll help boost that opioid, because you're going to run into it. Your doctors are going to talk to you about it, and they're going to recommend it, and it's going to help a lot of people. But I want to close this out. It is not going to substitute for people who right now are very ill and need palliative care and need high dose opioids. It's going to help a lot of people, but it's not going to work for everybody. Okay, I'd like to go on to that. We've got a very interesting guest tonight. And Jamie, if you can bring her in.
Yes, sir. Okay, Christine, welcome to Doc Talks. I know you've been here with us many times. It's so good to have you here. Welcome, Christine.
Thank you for having me.
Christine, can you hear me?
Yes, sir. How are you?
Well, pretty good. How's Vegas these days? You've been in the news a lot.
Yeah, it's finally cooling down.
Is that right?
Yeah, right now it's really windy, so my allergies are, you'll have to excuse me.
Okay. Now, do you live in right in Vegas, or are you outside?
Yeah, I live right in Vegas. I'm about 15 minutes from the Strip.
About 15 minutes trip. How long have you been there?
I've been going on 3 years now.
Again, okay. How did you happen to settle in Vegas?
I have a grandmother here.
Very good. Now, I know quite a bit about your case, but I think it'll be very interesting for people to hear about it. Now, you're quite young. How old are you now?
44.
You're 44. And tell me how old were you when you first got ill and started developing pain and disease problems?
I was probably about 4 or 5. I caught pneumonia for the first time. To date, I've had pneumonia 20 times.
Uh-huh. Okay. Now, that's a little unusual.
Yeah, it is.
How did it happen that you caught pneumonia that many times?
They found an artery that was malfunctioned, and it was pumping blood into my lung. And so I had caught pneumonia so many times, and they found it by accident by doing a stomach CAT scan.
Uh-huh. Right.
And so just happened to catch it, and then they'd have to, cut me open and take half my lung.
Right. Is part of your lung gone? You've had lung removal?
Correct. I have half a left lung.
Half. Okay. Of course, now are you supposed to have one of the connective tissue diseases?
I do. I've been going through a bunch of labs with my primary for the last couple of years, and I see many doctors. Rheumatoid. I see diabetes specialist because I have type 2 diabetes, which is affecting every organ.
Now, which genetic connective tissue disease are you supposed to have?
Epstein-Barr virus.
Well, that's not a genetic disease, that's acquired, but do you have Ehlers-Danlos syndrome or Marfan's or hypermobile spectrum disorder? Have you been
Oh
given it?
yeah, they said it was the hypermobile.
The hypermobile, yes.
Yeah.
Can you bend your joints a lot?
Yes.
Okay. So how old were you when you were given the diagnosis of hypermobile spectrum disorder?
Oh, goodness. I think I was 20.
I think you were 20, Now, were you able to finish high school?
I did not. I did finish it eventually a couple years later, but I did not finish when I was supposed to.
Okay, right. And you mentioned Epstein-Barr a while ago. Did you have infectious mononucleosis, or did they think that infection was tied to your pneumonias?
I think it was tied to my pneumonias. We're still finding a lot out. It's hard because the doctors here, it's like you get 10 minutes with them and you have to wrap up everything in that 10 minutes.
Right.
So it's
You
like
gotta be,
they just
yeah,
you to specialist all the time.
right. Okay. Now, when when's the last time you had a pneumonia?
Oh, last year.
Last year, okay. And when did you somewhere along the line had your spine problems. Now, how old were you when you developed the spine problems?
About 7.
About 7. So you've had spine and back problems since age 7?
Yeah. I fell out of a two-story tree, broke my tailbone and a couple ribs. So everything started then.
Yeah. So let me put it this way. In other words, you were born at a high risk to become an intractable pain patient since you have hypermobile spectrum disorder, right? So that's one.
Correct.
And then you fell out of a tree at age 12 and broke your
7.
back?
Yeah, 7.
In other words, you were a sitting duck by age 15 for the viruses and everything to invade you.
Yep.
Yep. Okay. And now you've also managed to have a couple of dozen infections. When did you, and how many back surgeries have you had now?
I've had a total of 3.
Total of 3.
They want to do more, but I just won't.
Yeah, that's it, huh? Okay. Now, what caused what did they say was wrong with your spine to require surgery?
The first time I was supposed to just have a laminectomy because I had a bulging disc.
Okay.
That turned into a raging infection. That put me in the hospital itself for a month or 2 with a PICC line. And they had to clean me out. Those 2 surgeries were 9 days apart.
When was your last surgery?
2016. So it's been 8 years now.
Been 8 years now. When did you find out that you had Epstein-Barr?
A couple of years ago, was that a couple of years ago? Gosh, time flies.
Yeah, it sure does. Well,
Um,
at least your time is flying. You're not ended it yet.
yeah. I think it was before I was your patient.
Okay.
Oh, it was before, like in the early 2010, somewhere around there.
Why was the test taken at that time? Or did I take it? I mean, I don't remember.
Sure. I don't remember. But I do remember being your when I was your patient, we actually redid the test, which is in my file.
Yeah.
So
Yes. Did you have other viruses that were also positive?
yeah, they thought for a while it was lupus.
Uh-huh.
But my lupus came back last year, came out clean.
Yeah, I saw that. Yeah.
So yeah, so that was good. So we still have a lot of digging to do though.
Do you remember either your first Epstein-Barr tests or later tests on what we were told by any chance?
Oh gosh, I'm so bad with remembering that kind of stuff. I'd have
Uh-huh.
to go back and look at my file.
Yeah. All right. Have you, do your doctors, now let me just, hate to put it this way. You've got hypermobile disorder. That'll usually get you thrown out of a doctor's office. Then you end up with all these spine problems and pneumonias. That'll usually get you thrown out of the doctor's office. Are they still seeing you?
Not really. Nobody wants to see me. Every time I go in to see my primary, she's like, "What are you doing in here again?"
Uh-huh.
So, yeah. Thank God I found somebody good and close to my heart, because if not, I wouldn't be treated right now.
And have you found a doctor you can get along with?
Oh yeah, he's amazing.
Oh, good, good.
Yeah.
Well, I'm glad
Many
to hear. And how long have you been seeing him?
Oh gosh, I think I've been with him for February will be 3 years already.
Okay. Uh, are you able to walk, or do you have to walk with a cane or a
I
wheelchair?
do have I do have my canes. I do have my walker when I go to the grocery store. Um, my 85-year-old grandma can outwalk me, which is pretty shocking. Um, she doesn't use a walker and I do. So
Uh-huh. All right. Somebody just asked a question here, which is a good question. What kind of a doctor is the one that you're getting along with? Is it an internist, rheumatologist, general practitioner? What kind of a doctor is the doctor that you like?
oh, it's Dr. Ibsen.
Oh, Dr. Ibsen. Oh, and you like him. Well, we know that. All right.
He's really good.
Well, then we wouldn't have him on the show if he wasn't that good.
Yeah, so it's Dr. Ibsen. He saved my life. I get along very well. He listens. Everybody should know him by now. So
Well, I've actually tried to package him and sell him, and I'm having some luck, but they outlawed slavery, so I haven't had the luck I was hoping to.
yeah, yeah, I got lucky with him.
Next question. Do you want to tell us a little bit about you're 44 now. How long do you think you'll live?
If I keep up my physical therapy, I probably got a good 20, 25 years left. I mean, I have a lot of kidney damage, pink, of course, my diabetes. I just like the only organ that I don't have an issue with is my heart.
Mm-hmm.
So I
Okay.
got a clean bill of health on my heart, but not my kidneys, pancreas, spleen, and all that.
Yeah. Just a quick note, then I want to come back to something. The literature is a little scanty and sparse on this, but up until the last 10 years, when we really knew what hypermobile meant and how to treat some of these things, the life expectancy for people with your condition was only about 40, 42 years of age. Now we do expect you to live another 20 years, and we think we can get you there too. And so I think we've made we've got a long ways to go in what we want to do and how we want to do it, but you certainly are a good example. I think you'll make it another 20 years. Do you want to tell us a little bit about your program, what you're doing
Yeah.
to
So
your stay
one
alive,
thing,
stay happy?
one thing
Yeah, go ahead.
I take is the injectable hydromorphone, which is completely saved my life, I think, many times. That really helps with my pain. I do use CBD and THC. I use rubs. I use tinctures. For the days that I just cannot get out of bed, the THC and the CBD rubs really help.
And what are they again?
It's a CBD, THC. It's a muscle
Okay,
rub.
all right.
And so I use that also with my grandmother because she broke her neck years ago. And so that really tends to help. I do have my methadone that I use, which for me helps a little bit
Yeah.
with
How much? What's your dose on the methadone?
the methadone. Right now, the pharmacies only allow me to have 40 milligrams a day.
It's 10, is it in 10 milligram tablets?
Yeah, I'm allowed to have 1 10 milligram every 6 hours.
Okay, all right. Yeah, because that's still that's on your sanctioned list, you see.
Yeah.
And yeah, so you're in pretty good shape then. Okay. Uh, are you doing anything about your Epstein-Barr virus?
I haven't lately. I've been wanting to start your protocols, but I just haven't had the money lately. But yeah, I'm going to be starting the what is it, the DHEA and other sorts of supplements.
Okay. Yeah. Well, we'll be coming out with as cheap a thing as we can get by with. Okay. So stay tuned. Christine, I want to switch over here now to the that lovable doctor of yours. And Mark, I see you're still on here. Uh, I'd like to first off, what do you got? What do you think we can get out of Christine that might help somebody? You got some good questions or comments about her?
Well, Christine is a fountain of information about chronic pain therapy because she used to run a pain clinic. So she knows what's going on in the background, how to make things happen in the background, and is a real resource to me for that, to explain to me like why this and why that. So she's been profoundly helpful to patients who I've tried to continue the hydromorphone for, and onboarding them and that sort of thing. So big help to me and to most of our patients, particularly new ones. And I think that advocacy wise, Christine can tell a really good story about the runaround she's gotten from standard pharmacies, particularly in Las Vegas, which is why she's not getting any significant amount of pain medication from there. So it's one of those areas where the pharmacists have been reluctant to go above a certain level, and are completely militantly ignorant about the idea of a hypermetabolizer of opiates. They don't believe that that's true. They think it's bogus, and they completely ignore it. And that's probably fair because everybody seems to ignore that piece of information, that science. There's so much
Equal,
stupidity going
equal
on.
opportunity.
And,
Yeah. Mhm.
yeah. I think that right now medicine is full of people who are afraid of badness. The fear is so diffuse that it's not specific to one particular thing or another. It's like I can't be visible to anybody, because as soon as they recognize me, then I'm on their radar. And I've been on the radar of the Montana board for 18 years. So I get it. People want to stay invisible. They don't want what happened to me to happen to them. So when you make a few examples, I think Dr. Parker made the best analogy. Called it the Russian warning shot. Russian agents would walk into a room and shoot somebody, and then say, "Anybody else want to argue with us?" and so but it's basically regulation by terror. And so when you're afraid of everything, then you really can't sort out what's real and what's not.
But yeah, she actually, yeah, with all her troubles, and she's made it to age 44, she's kind of a remarkable person. Because in my experience, when you've got that genetic connective tissue disease, and then you get a trauma on top of it, Epstein-Barr on top of it, and she's made it to age 44 and doing pretty well. And here's my real question. Her pain regimen to me is dynamite. I mean, methadone 4 times a day. May not be where she wants to be. She's taking some CBD and marijuana. She's getting the flare treatment with the hydromorphone. And that's kind of within the sanctions, that regimen, believe it or not. Can you make a comment about that? Because methadone seems to be making a comeback, and throughout a lot of the states, and 4 milligram, and it's methadone 10 milligrams 4 times a day, and then if you do add the boosters and the flare treatments with it, that's a pretty good treatment. You have any comments about that? I mean, I like what she's on, and I'm not surprised she's still with us, and may go on 20 more years.
Well, let's ask Christine.
So, yeah, I mean, I do have a good pain regimen if it could stay steady. The issues that I come across a lot is pharmacies not having the medications, or doctor will write for 180 and I'll get 120, or I was getting a runaround for 8 months straight. It took me just to get one prescription. Finally, like it took this just to get 80, and it was like pulling teeth. So, and then now with Anazao is a good pharmacy for the hydromorphone. But with the hurricanes, they got contaminated. So, trying to keep my meds going steady is kind of hard with the pharmacy issues I've been having for the last 2 years. So, but I mean, once I get it going straight, it's a good regimen.
Good. Yeah, well, that's very good information. Might just add to it, one of the problems that really restricts doctors, when you have these kind of sanctions, here's what we approve of. Everybody's different, and a doctor needs to have the flexibility to try different things, different dosages and different opioids, different boosters, to find one that works. And so the worst thing in the world to me about sanctions is that you really tie the doctor's hands. You've got 1, 2, 3, 4, and you can't experiment. And that's what medicine's all about, is trying different things to find a program that works. So we'll have to keep trying to advocate and try to get understanding that you just can't put people, square pegs in a round hole. Thank you very much. Mark, I'd like to come back to you, if I might. Tell us what you're hearing, what you're seeing about the buprenorphine movement. I want to call it a movement. I didn't say it was a positive movement. I'm just saying it's moving all over the country. What's your observations? What have you heard?
Well,
what are you seeing? What are you thinking?
I would call it a bowel movement.
Well, that's maybe a pretty good analogy. Yeah.
A steaming pile of poop. There's money behind it. A lot of people are invested in these companies that manufacture these half-assed opiates, and they call them opiates, but they're highly ineffective. Maybe I've seen 2 patients in 15 years do well with buprenorphine. I've seen doctors start patients on buprenorphine who are already on another opiate, and they really suffer. So it's there's a whole lot of unwritten rules about this, and I'm glad to see this protocol come out. I want to know whose fingerprints are on it so that we can sue them. But ultimately, I I want to defer to one of the things you said earlier in a different program, where you were wondering where are the academic institutions, and why aren't they coming up with answers for us? And this light bulb went off the other day. It's like the academic institutions, like the Cleveland Clinic, where I had my bypass done, and they are economic juggernauts now, and they cannot deviate from government protocols. And so it's all about maintaining their grants and their dollars and the cash flow, and they can't afford to have any doctors go offline, and lose part of their staff because they're not following the CDC guidelines or something like that. So I think that this has got to transform, like we're doing, into a grassroots movement, and we are the model for a grassroots movement. It just needs to grow.
Yeah, I'm so glad you say that. Let me also chime in with exactly what you're saying. That's not well appreciated. When you call them economic juggernauts, boy, I mean, that's the understatement. You go to towns like Cleveland or Pittsburgh, and some of these towns, these institutions have gotten to be so big, so costly, they can't afford to deal with an unusual or rare disease. Now, everybody watching this doesn't understand. You wouldn't be even interested in this program if you had a common problem. We're talking here about people who have an unusual or rare disease like arachnoiditis, pudendal neuropathy, RSD. And so you're right out front. All of you watching this and all the people who are going to watch this as a follow-up, you've got to understand you're a rare bird. And they almost can't afford to see you. And they won't. They'll pass you right on. So bottom line is, we need protocols, and we need a lot of self-help, a lot of self-support. I don't quite know what the answer is to all of it, except keep trying to help one little step at a time. But any rare disease these days is kind of on our own. We're going to have to try to figure out what to do, because nobody's going to come to our research help. No, these big institutions are there. For example, in a typical medical school university setting today, now this is not true in all 50 states, but it's true in most of them, those doctors are there to teach a class once in a while to students, and the rest of the time, they're not to be in the research lab anymore. They're to be down there seeing patients, bringing in money, and the high paid money. Now, when I was there, a resident on the university staff, we'd not only teach people, but you spent the rest of your time doing research and writing papers. Today, they don't do that. Okay, so that's why I've kind of gotten to know some doctors who are doing private research through foundations like I'm doing, and on issues other than pain. And I'm delighted to see it, and I hope I can talk other doctors into doing the same thing when they get up in the years and want to do something other than that, because we need it. I don't see the universities coming back. They just their bills are too big to pay. Yeah, that's the way
That's the way I see it too. And the only thing I would add to what you're saying is that I now see that, we are dealing with rare diseases in our subgroup here. But the other thing I'm seeing everywhere in medicine is it takes extraordinary effort to achieve routine results in every case. And the juggernaut has so much momentum that, you want to get a dose of prednisone to somebody who's got asthma, it's like pulling teeth also. So it's because the pharmacists have become such gatekeepers, they feel responsible to analyze your entire practice style. And if your practice style doesn't meet their standards or what they're used to seeing, they get scared, and so it's just difficult to order anything that's
Out of the
effective. If it's effective, you can't have it. Basically, that's the way it is in our medicine.
Yeah. Well, let's close out with one good thing. I am starting to hear more and more doctors getting interested in these pain problems. The news about Epstein-Barr kind of gives them something they can treat and should treat, and it's bringing a few people in. And I think we ought to just recognize that we do have doctors, nurse practitioners, chiropractors, good medical people in every community are out there doing a lot of great humanitarian work, and they become a lot more like ministers. They do it because they love the work, not because they're going to make a lot of money. And I'm glad to see that trend. So I think we ought to recognize those people. And incidentally, I'll close out the program here. Take anything you learn on this program, any of our writings, anything that Mark puts out, I put out, take it to your medical practitioners. That's number one. Number two, let them know you appreciate them. And also ask, would you mind taking some patients who have the same problems I have? So I'll try to build a network of the people who care, and they're out there, and I think maybe we can continue to recruit some. With that, again, Christine, thank you for not just being here tonight, but for being an example of staying alive against all the odds. We acknowledge and appreciate what you've done. Jamie, as always, great program. Mark, your words are so good to hear. So good to hear. That's all I can say. With that, folks, we'll see you next week.
Thank you, Obi-Wan.
Good luck.
Thank you, everyone.